And for this portion of our chronic neurological disorders, we're going to look briefly at Parkinson's disease. Okay, so as we've talked about with a lot of these chronic neurological disorders, the signs and symptoms are very similar. So we'll try to break this down. There's not a lot of PowerPoints for this topic because we're going to focus on what is specific to Parkinson's. So let's talk about it. We know that Parkinson's disease is a progressively debilitating disease that affects our motor function. We talk a lot about the signs and symptoms of clients as the disease progresses and how we have to promote patient safety. And we have to do a lot of patient teaching, a lot of health promotions. So really, the only thing we have going for us is our medication regimen, which we're going to talk about as far as our dopamine medications and our anticholinergic medications, and patient safety, patient teaching. So primarily, Parkinson's disease is going to focus on increasing the amount of dopamine or decreasing the amount of acetylcholine. And we're going to use that medications, we're going to use our anticholinergic medications to decrease acetylcholine. So you do have the 5 stages. Again, I don't think that you're going to be asked to identify the 5 different stages of Parkinson's disease on NCLEX. It's a progressively debilitating disease that affects the motor system. Right, and as we go, make sure that we're going to diagnose it probably based upon the client's signs and symptoms, and then we're going to do health promotion activities that are going to help the client maintain their normal ADLs. So things that we would expect, there's a lot. It's fatigue, decreased dexterity, stoop posture, slow shuffling, propulsive gait. It's kind of like they're pushing themselves forward. A slow, monotonous speech, so everything we know is kind of slowing down. You're going to have inattention tremors, so unlike MS, where we have tremors with movement, here we could have tremors or a pill rolling kind of activity with our fingers at rest. You're still going to expect some sort of muscle rigidity. Some of these rhythmic interruptions can be restrictive, mildly or totally. Depends on the severity of your signs and symptoms. So that's our bradykinesia or akinesia, a mask-like expression. We're going to see that pop up again, I think, when we talk about myasthenia gravis. Changes in your blood pressure and the autonomic nervous system. So you see flushing, diaphoresis. We've talked about difficulty chewing and swallowing. That's a huge piece of every NCLEX question I've ever seen about Parkinson's disease. Increased drooling, dysarthria, progressive weakness that interferes with the ADLs, mood swings, cognitive impairment. So it's going to present like dementia, and constipation. As far as nursing care for Parkinson's, it's making sure that we are giving the medications as prescribed and adjusting our doses as prescribed. We'll look at some of those medications in the following slides. We're going to make sure that we are monitoring that client for aspiration, for difficulty swallowing, dysphagia, all the good things that we've already talked about. Encourage fluids. Again, we don't want to change anything, but we do have to maybe think about long term that if these folks aren't moving a whole lot, they're going to be increased risk for a lot of the other comorbidities. Small, more frequent meals, right? They have difficulties chewing or swallowing. It's going to take more energy, so the smaller, more frequent meals will be better for that client. Make sure that they're sitting upright. Make sure that we're providing them with the resources to maintain some form of independence, and look at that overall diet to make sure that they are not malnourished. We're still going to encourage them to exercise, but just again, provide them with opportunities to rest. if we need to use any kind of assistive devices, or if we need to participate in range of motion exercises. We can teach them that while exercising, we can occasionally stop. That's going to help decrease the risk of injury. Again, provide periods of rest, help them with their ADLs as needed, promote client communication. So if you have the dysarthria, something like that, that we're having that difficulty speaking or difficulty understanding the client, we want to make sure that they can communicate. And then obviously monitor long term for any mental or cognitive status changes. The other big question I see on our practice exams is, making sure that the clients understand that these dopaminergic medications and the medications in general for Parkinson's disease might take a long time to start taking effect. It's not an immediate thing like we would associate with a blood pressure pill. So to increase the dopamine, we would consider levodopa / carbidopa combination medication. We know, again, that that's probably going to need to be adjusted. The dose is going to need to be adjusted as time goes. Our dopamine agonists, so things that are going to help dopamine get to those receptor sites better, bromocriptine, ropinirole, and pramipexole. I had to put that one on there because that's a big word. We need to monitor for changes in blood pressure, dyskinesia, hallucinations. And then your anticholinergics, the benzotropine, like atropine. All cholinergics cause dry mouth, constipation, urinary retention, and acute confusion. So unfortunately, if we look at those medications and we look at the side effects, that we understand that a lot of the side effects of the medications are the exact same side effects of Parkinson's disease. So again, it would be really hard for us to differentiate one from the other. So it would come more from which medication should the nurse expect. And generally, the big one is going to be levodopa, carbidopa. With our dopaminergic medications, you want to monitor for a wearing off effect. So you have, again, issues with movement. And again, that's just telling you that dose needs to be adjusted. We've talked about our dopamine and our anticholinergic medications and their side effects. You can do COMT inhibitors, and that's going to help decrease the breakdown of dopamine. So entacapone, but just make sure that we're assessing for bowel and bladder issues, and maybe a little bit of patient teaching about we kind of expect a darker, more amber colored urine. Your MAO-B inhibitors help with reduce the wearing off phenomenon. So a couple of those that we could expect just with any MAOI medication, MAO-BI medication. We're going to tell them to avoid foods high in thiamine, which can lead to a hypertensive crisis. So a lot's going on during this whole long-term disease process. You see that you have these different kind of issues with pseudo-Parkinsonisms, where we're talking about the posture, the rigidity, the movement, the tremors. You can have extrapyramidal disorders, which can lead to those things as well from side effects of the medications. If we look at that tardive dyskinesia. So with acute dystonia, you have facial grimacing, you have involuntary upward eye movement, you have, again, muscle spasms. But the big one here is laryngeal spasms, which is an airway issue. So it's, again, airway, breathing, circulation. The akathisia, it's like restless leg syndrome. It's, this extreme restlessness, trouble standing still. There's a lot of pacing or constant motion. And the tardive dyskinesia is protrusions and rolling of the tongue, smacking, sucking, of the lips. It's a chewing motion. You still have some sort of facial dyskinesias, and again, involuntary movements. Unfortunately, there are no definitive diagnostic exams. It's going to be based upon the client's health and history. What signs and symptoms are we experiencing? If we put them on the dopaminergic medications, the levodopa, carbidopa, does it make the symptoms better? Lots of things to be monitoring for with Parkinson's disease: aspiration pneumonia, swallowing precautions. Make sure somebody is there to monitor for aspiration. Make sure that we're addressing any kind of acute changes in LOC. Remember, long-term dementia and memory deficits may be expected, but if we are having acute changes, then we probably need to start with airway, breathing, circulation. And that's really it for Parkinson's disease. So not a whole lot I can do. Promote patient safety, make sure that we're giving prescribed medications, make sure we're monitoring for side effects and the wearing off phenomenon. But if I were looking at it from an NCLEX perspective, it would be a lot of safety and infectious control type of questions.